So my career in medicine began obviously many years ago. I'm sort of old at this point. And I graduated from medical school in 1961. The world of medicine was totally different then than it is now. I was in the third class, graduating class of Albert Einstein College of Medicine in New York City, Bronx, New York. Graduated from medical school. I obtained an internship at Kings County Hospital in Brooklyn. Our training at the medical school was not particularly great from a clinical point of view, but the internship at Kings County was really terrific. It actually converted me from a medical degree to a young doctor. The interesting thing about Kings County was as follows, because it influenced my choice of career later on, was that in 1961, there was not a lot of interest in what's called medical chest disorders, diseases. Most of the interest was in tuberculosis. So during my 1 year at Kings County, I took some elective time in a tuberculosis building that they had, ward that they had at the hospital. It was 6, 7, 8 floors of patients with tuberculosis. The top floor of that building was a small ward dedicated to people who had non-tuberculous lung disease. And it was fascinating to see that transition, because within a few years, the whole shift in lung disease shifted from taking care of people with tuberculosis to emphasizing the care of patients with non-tuberculous conventional medical disorders of the chest. I moved from Kings County to Boston City Hospital the following year, where I spent several years as a resident and in medicine, and that was a medical residency that had no particular stress on lung diseases. But I befriended some people who were in the pulmonary or lung disease medical section of the hospital. And when I finished my training as a resident, I took a fellowship in lung disease there, the lung station at Boston City Hospital, which I did for 2 or 3 years. And at that point, the care of people with medical lungs issues such as asthma, bronchitis, emphysema, etc., was in its infancy. So I was in the beginning, though I didn't know I was in on the beginning, of a rapid change in what the emphasis would be in taking care of patients with lung disease. There were no formal mechanisms for doing studies or interventions on such patients. The medical system was a little more loose, unregulated. In any event, I developed some methods for putting such patients to sleep and putting a tube in their lungs and putting them on a primitive ventilator, which was called an IPPB machine, which is an intermittent positive pressure device. And I did this on a few patients on my own. I go to one of my mentors and told him what I did, and he said, "You did what? You did what?" I said, "Yeah." I said, and they're doing all right. So it led to a study which I think became sort of very important in the evolution of managing such patients, because it's a common problem for people with lung disease to have a superimposed acute problem that lasts only a short while but needs support for a period of time, such as an infection, clear their secretions, support their breathing, and then get them off the breathing machine for them to continue with whatever, their usual lifestyle. So that was a big turning point for me, and I think it was a somewhat important point in the history of the management of patients with lung disease. So I was at Boston City Hospital for about in that capacity for about 5, 6, 7 years. And I eventually became the associate chief of medicine on one of the medical departments at the hospital. The chief of the department was a man named Harold Jagers. He was fairly well known. And one day he came to me and he said, "I'm moving to Worcester where they're developing a new medical school. Why don't you come and set up a pulmonary service there?" Because there was very limited, outside of the city of Boston in 1970s, say, there was very limited pulmonary capabilities, such as advanced pulmonary testing, lung testing, and treatment interventions. He recruited me to become chief of pulmonary there. So I went and opened up a fairly large department of respiratory diseases, which included tuberculosis, and it was probably one of the largest and most sophisticated pulmonary units outside of the city of Boston in Massachusetts at that time. Of course, since then, things have changed a lot. When I retired, I remember very vividly walking out the door of my home one night, looking up at the sky and saying, "What's all that about?" And since I was very close by to Wellesley College, which had a very nice, very advanced astronomy department, I spent the next 10 or 12 years immersed in studying astronomy and astrophysics. So the astronomy sort of culminated in my years of professional interest and what have you, and I turned to other things after leaving the astronomy department at Wellesley College. Became interested in writing poetry and doing photography with converting digital photographs to what I call impressionistic paintings. And I've had 4 or 5 exhibits of that work, and I continue to do that and write poetry in my more recent years. But the thing that always intrigued me about medicine was that once you're a physician, you assume an interesting and an important responsibility. Very few people are given that responsibility in life. The need to be a human being who cares about other people and put your life behind their needs so that humans in distress can rely on you, that you're doing the very best that your judgment and experience will allow. And that's the critical lesson of my life, to be there for people who are in serious problems, who need your help. There is nothing more distressing to many people, patients, people, human beings, than being unable to breathe. The sensation of shortness of breath, otherwise known as dyspnea, is obnoxious. It's terrible. People have a hard time existing under those conditions. So I was very fortunate that I made that career choice. I had bad days, I had good days. Was I perfect? No. Was I imperfect? Of course. Did I try? Very hard. And I have a lot of patients that still stay in touch with me because the personal relationship I developed with my patients, I think, was useful for me as a human being. The question is how I would like to be remembered. We're frail. We're all frail. We do the best we can in our lives. Some of us do, some of us don't, but whatever. We're insignificant. In the scheme of this universe, we have found ourselves, and we look up. The advanced understanding of astrophysical phenomena have been gigantic in the past, not even 100 years. And the more we look up and the more we see of what we're involved with as human beings, we see how minuscule we really are, how unimportant we really are. And so my own personal attitude and philosophy is to live my life right now. Dying is part of human existence. Someday it will not be. And when it's over, it's over. So there's nothing to remember.